COVID-19 has put digital health in the spotlight. There's never been a more important time to get digital tools to patients and to physicians. As a recent NYU medical student graduate and a digital health innovator, I've personally never felt more motivated to get these tools to my colleagues and to patients. But that's exactly why I think we need to stop and think about what our first steps are. We need to think about building the right foundation for innovation. It's my strong belief that early collaboration between physicians, patients, and innovators is utterly necessary to achieving a truly digitally enabled future. Collaboration needs to be the first step in innovation and not an afterthought. It needs to be part of digital medicine's DNA. I want to approach collaboration and innovation from a few different stakeholders' point of views. Healthcare is incredibly complex and involves far more stakeholders than just the physician, the innovator, and the patient. But today, I want to focus on these three central stakeholders and take a deep dive into each. First, looking at where we are today, and then looking at where we need to go for the future. While we've made some great strides in digital health, with a huge focus on interoperability, on patient-centered design, and on integration into physician workflows, there's still a lot of work to be done. Taking a look at each of our central stakeholders, first at providers, we've made great strides in urging physicians to adopt tech, but physicians still feel like their training isn't preparing them to adopt a digital practice. Second, taking a look at innovators, our second set of stakeholders, there's been a lot of progress in innovators' approach to validation and their respect for needing to involve medical professionals early when innovating, but there's still very limited best practices on how they should approach validating their solutions. And third, taking a look at patients, the recipients of care, they've had a huge demand for digital tools for a long time now, but these tools still haven't made it into traditional settings. First, I want to analyze where medical education is today with regards to preparing physicians to be digitally enabled providers of care. Doctors currently recognize the need for technology, but have had minimal to no training in how to use technology in their practice. I can tell you from personal experience, I did learn how to use an electronic medical record, how to input orders via the computer, but I had no training in telemedicine or in remote monitoring whatsoever, and I graduated this year. Most medical curriculums, in fact, haven't changed much in the past couple of decades. Our administrators understandably don't want to sacrifice teaching us critical clinical skills so we can learn what it takes to become a fantastic provider to our patients. But they haven't really recognized the need to prepare us for the future, to prepare us to use tech in our practice, and that's coming. If you take a look at this chart, for instance, only 20% of the surveyed physicians who were medical students during this time felt like their medical training prepared them for new technology in healthcare. And in fact, many of these physicians are actually kind of being forced to seek out additional coursework outside of their training in data science and even in kind of machine learning and artificial intelligence because they feel so underprepared for this new wave of tech, which is going to impact their practice. The future is clinicians who are armed with the skills to integrate technology into their practice, where collaboration between tech and industry is commonplace. I think we can best enable this transformation by looking at the curriculum and enabling it for the future, by creating flexible pathways and tech-oriented experiences for our trainees, and then third, by creating communities where physicians and physicians in training can come to not only share learnings, but also opportunities to gain practical experience with technology. The first focus must be on revamping the medical curriculum. While there are some institutions and universities that have done this, it's really not widespread at all. We need to expose medical students early on in their training, incorporating technology side by side with their learning of clinical skills, bedside manner, and pathophysiology. One institution that's taken the lead in bringing technology into the classroom is actually Case Western in Ohio, which is pictured on the right of the slides here. You can see a student is actually using a HoloLens or augmented reality to learn the anatomy of the heart. And this is incredibly beneficial to students because they can continuously access this learning from outside the confines of the lab. Another way we're seeing schools integrate informatics and learning about data analytics into their training is actually at NYU. Every second year medical student does a healthcare by the numbers project where they're given a complex data set, told to ask a clinical question, and then they have to wrestle with the data, assess it, and analyze it to come to an answer. And I can't talk about the transformation of education without mentioning what the pandemic has done. Prior to COVID-19, I tried to pursue an elective in a combination of digital medicine and telemedicine, and there were none to be found at NYU. And this was only about 6 months ago. I had to create my own elective in digital medicine and gain approval from the dean. Now, and it's only been a month or two, telemedicine has become a required part of the curriculum. And that just goes to show that this transformation of the curriculum is here and necessary, and we likely aren't going to go back after, the pandemic has created these changes. Another way we can enable digital adoption amongst medical trainees is providing flexibility during their 4 years and after. There are a couple of ways that medical schools are approaching this. For example, Mount Sinai, which is a medical school on the Upper East Side of New York City, has a program called the Mount Sinai FlexMed program. This is an early admissions program where Mount Sinai will admit actually sophomores in college into the medical school to start 2 years later. And during the interim, they don't have to go through all of the typical pre-med courses, but rather can pursue courses of their choosing. I've interacted with a number of these students, and these days, a ton of them have tech backgrounds in data science and computer science. So, this allows them to have some flexibility in their learning prior to starting medical school. Another way other schools are approaching this is allowing these flexible pathways during school. So I actually decided to do an MD MBA degree where I got to pursue MBA coursework between my 3rd and 4th year of medical school. And there are some students that choose to use this same time to do research. Another way that we can introduce flexibility into medical training is by allowing for students to do fellowships or encouraging them to do fellowships in areas such as bioinformatics and biodesign. In addition to transforming the structure of training and also transforming, the way that medical students are taught by introducing technology to the curriculum, we can also help create environments for organic collaboration, such as these communities, physician innovator communities. One that I want to point out is the AMA's, or the American Medical Association's Physician Innovation Network, or PIN. PIN's an online community that not only brings physicians together who can share career experiences, share advice about working with industry, but it actually allows for various companies to post opportunities for physicians to consult. Another kind of like-minded group is MD++. MD++ is actually a group of medical students that started this year. It was started by a few students in New York City, including myself, who had backgrounds in digital medicine, wanted to find like-minded peers, but also wanted to work together to approach residency leaderships and approach medical student leadership to help kind of encourage them to encourage students to pursue these flexible pathways that I mentioned in the previous slide. A second group of stakeholders that I want to address are entrepreneurs and innovators. While so much more goes into building a successful digital solution than just digital solution validation, I think that proving the efficacy, the cost effectiveness, and the safety of a digital tool can often be what divides the successful from unsuccessful solutions. So I want to take a deep dive into that now and speak about where we are today and where we could be in the future. Again, after an era of snake oil solutions that showed very little clinical impact and had very little respect for evidence or clinical usability, entrepreneurs these days, for the most part, recognize that they need to prove impact, safety, and cost effectiveness of the tools that they're putting out into the world. But there's still a ton of complexity and ambiguity in how they navigate that process. It's even hard for entrepreneurs and innovators who don't have access to providers and are external to hospital systems to even understand if their particular solution needs validation. And to kind of make matters even more confusing here, hospitals actually really struggle to guide these entrepreneurs through this process. Number one, because they just don't have the time to do it or the bandwidth. And two, they're new to this process as well. They don't have a playbook either. A number of different organizations are trying to help innovators answer these questions, like what types of products need clinical validation? How do I construct a study? And three, who could I contact to help me run this study? These organizations are tackling these questions in a couple of different ways. While some are providing support through access to portfolio companies that have been through similar challenges and through venture capital and accelerators, some are creating toolkits and guidelines for startups. There are some organizations that are just doing knowledge sharing on best practices. And then fourth, there are actually organizations like Evidation Health and like Node Health, which is an organization that I'm going to speak to slightly later, that are actually providing clinical validation services for startups and for innovators. While there are a ton of different organizations that you can see here with a lot of smart minds that are putting effort towards standardization of these validation practices, there's still a lot of confusion around basic terms around what types of digital health products fit into which categories. And this is important because the category that a digital tool fits in, whether it's a digital health, digital medicine, or a digital therapeutic, has a lot of bearing on the amount of regulatory oversight or amount of clinical validation that the particular category requires. So I want to take a little bit of time to dive into these different categories and just provide a little bit more structure around how we define them. A couple of different organizations, including Node Health, came together to try to put some structure around this. And there is still ambiguity between which tools lie within each of these categories, but hopefully these definitions will help you to think a little bit more about what types of tools need a level of validation. So first, kind of looking at digital health, which is our broadest category here, it encompasses pretty much any tool that has a healthcare or a wellness focus. So think fitness apps, electronic medical records, and pure digital health tools rarely require clinical evidence because they pose less of a risk or almost no risk to patient health. The second more narrow category is digital medicine. And digital medicine tools are generally tools that aid in the measurement or intervention for a particular disease. And this could be a remote monitoring tool, potentially a diagnostic tool. And these tools do require clinical evidence because they pose more of a safety risk to patients. Then jumping into the third category, which is the most narrow in the dark blue, digital therapeutics. Digital therapeutics are generally software-based. They can be hardware-based as well, but they actually aid in the prevention, treatment, or management of a specific disease. And These tools require the most regulatory oversight because they pose the biggest risk to potentially to patient safety. So they require clinical evidence, and they also require real-world outcomes. Next, I just want to jump into an example from an organization that I'm on the board of and helped start Node Health. And I'm just going to give you a little bit of an overview on who the organization is, who our members are, and then the type of clinical validation services that we offer. So we're a nonprofit that's governed by health systems. We have over 32 health system partners. We consider ourselves a home for evidence-based digital medicine. And in addition to having events, an annual conference where we do knowledge sharing and have our various partners present on the pilots they're running that are for evidence-based solutions, we also provide clinical validation services, which I'm going to run through next. So we can actually support every step of the validation process. And generally, startups will come to us for one of two reasons. First, they don't know if they need a study, and they would like us to kind of analyze where they fit into provider workflow, for example. And just they want help with understanding what type of study they might need if they do need one. And two, they know they need a study, and they want to kind of try to figure out where they should have that study, who their principal investigator might be. So just running through the different steps of the process. With discovery, I kind of alluded to this before, but this is generally startups that want to understand where they fit in, whether it's in provider workflow, understanding what type of study they need. We can help with that kind of first discovery part of the process. Second, protocol design. And this is generally kind of helping startups, once they know that they need a study, to figure out potentially what their primary endpoint should be, what their secondary endpoint should be. The third step is actually helping to run the study and kind of select sites. And we can also help with the IRB here, help the startup to assess and analyze the data collection. And then fourth, we can actually help with the publication or dissemination of the results that the startups or outcomes that they discover through their studies. And importantly, I do want to mention that we see ourselves as facilitators of this process. We don't, sponsor a particular startup, but we actually look to create partnerships between researchers and the startup if there is mutual interest there. So third, and likely most importantly, is, especially to the audience here, is the patient. I truly believe that collaboration between innovators and physicians is extremely important, but patient input is absolutely essential to care delivery. And patients probably have been the biggest force in driving innovation forward. If you take a look at this chart from Rock Health and Stanford, you can see that over the past 4 years up until 2019, we've only seen a steady increase in patient demand for digital tools and adoption of digital tools. And in 2020, this is just going to be off the chart because of what we've seen with the pandemic. But despite this demand, the prescription of digital medicine in traditional settings has been fairly rare. One exception that I wanted to point out because I think it's relevant to the audience today is the Tandem Control IQ automated insulin delivery system has seen a lot of prescription. And we've seen a massive transformation with COVID-19, but in 2019, only 30% of health system CEOs, or actually 38% of health system CEOs had no digital strategy whatsoever. So, I mean, the pandemic has just caused a lot of these health systems to have to massively turn around and stand up systems that were not even in place before there. And the explosion we've seen with telemedicine has been miraculous. To jump into it right here, COVID has completely transformed connected care. Telemedicine has completely taken off because not only has there been a desperate need, but clinicians have been able to practice across state lines. Other policy changes that we've seen driving connected care forward are that remote monitoring billing has been loosened, and it's now being covered not just for chronic conditions, but also for some acute conditions as well. And another change that we've seen through the pandemic is some relaxation in regulation for digital therapeutics. But I do want to talk about a few smaller innovative companies that even before the pandemic were leading the charge in kind of creating these connected care models. One example I want to point to that's in this vertical full stack care model category is Virta Health. Virta Health is a diabetes 2 focused solution that provides technology-driven bidirectional communication between patients and not just health coaches, but also physicians. They also track biometric data, and by bringing together this biometric data, physician and health coach recommendations, they're able to create a end-to-end connected program for diabetes 2 patients to reverse diabetes. Another great example I want to point to of one of these vertical full stack models, and vertical here being kind of focused on a specific population with a specific need, is Tia. Tia is a women's health company that started as actually a chatbot to help women with birth control decisions, but morphed into kind of a full service end-to-end platform that has not only virtual care, but also a brick and mortar physical clinic for women patients to come see that offers wellness services, primary care services, and OBGYN services. And like Virta, they also offer a way for patients to bidirectionally communicate with their providers. And one kind of surprising stat I did want to point to, going back to the explosion of telemedicine during COVID, is at my home institution, NYU. During March of 2020 alone, we saw almost a 700% increase in urgent care visits and over a 4,000% increase in non-urgent care visits. And I don't think that with all of these policy changes, we're going back anytime soon. I just think this is accelerated connected care. We're in a special period of time now where the need to tackle healthcare issues is in the spotlight. The government's listening, the whole world is listening. But to do that, we need to enable early collaboration from the beginning and not bring in central stakeholders when it's already too late. We need to work to enable providers to practice in a digitally enabled future by transforming medical education. We need to help innovators and guide them through the validation process and give them the resources to do so. And third, we need to listen to our patients. They've been demanding digitally enabled connected care for a long time now, and we have to meet their complex needs. While healthcare lags behind other industries and innovation, collaboration has always been part of our DNA. We've gotten through this crisis because of collaboration, and not just because of the collaboration and teamwork between essential workers, frontline providers, including patient transport, and nurses and doctors, but because of technologists as well. Without technologists, we wouldn't have been able to stand up virtual care that led to those massive increases in percentage in virtual visits across health systems. So I encourage you in that spirit to go out and collaborate with your fellow innovators here. Now is the time to change healthcare, and use the Diabetes DData Exchange Conference to do so.